have come to board you for next 1 hour or 1.5 hours. But this session, in contrast to my last session on 26th, I would like you to put your, if you have any questions, any queries, anything you would like to add, ask, share with us during the talk, you can do that. That will be a positive, contribution towards this topic. It's a very, very common topic of red eye. I think more than 50% of the presentation in the outdoor clinic, one way or the other, have red eye. Whether they complain about the red eye or they have red eye incidentally, it is very, very common in especially our part of the world. Now the goals and objectives of the presentation is that the participant should be able to know the common red eye presentation in the clinics and to differentiate serious sight threatening condition. Out of these red eye, there are a couple of conditions which are very, very dangerous, serious, and they lead to serious outcome as far as the vision is concerned, one way or the other. So it's important to differentiate, recognize, and properly refer them in time to salvage the vision and to educate the patient and relative correctly and scientifically. Now the presentation is more of a pictorial presentation, giving you the picture as well as the text, and I would like your comments during the presentation and of course at the end of the presentation as well. But you're most welcome to ask anything during the presentation. Now the outline of presentation is it is an overview of the differential diagnosis of red eye in GP practice. This particular topic is not common important for the GP. It is important for us as well in our outdoor eye clinics. And to learn more about the common and serious eye condition presented with red eye. Now, red eye is, I'm talking about red eye, which is of course not the one you're seeing here. This is a different red eye. We have brown eye. This is light color iris. This here, the iris color is red. The eye is not pathological. It's very normal eye. We are talking about red eye. This eye, this redness is different in the sense that it is not a normal situation that the eye should be red. The eye should be white. Of course, when we say white, we talk about the scleral part of the eyeball. Now we know that the front 1/6 diameter is the cornea and the rest 5/6 is the sclera, which in front is covered over by a conjunctiva. Now conjunctival vessels are normally, there are vessels, it's a transparent conjunctiva in normal situation in physiological condition, and the underlying sclera shines through it and we see the rest of the eye, less the cornea, as white eye. Now that's the area which becomes red in different eye conditions, different eye diseases, and is the commonest mode of presentation. Now this is what happens in a red eye. In red eye, the cornea remains, of course, if the cornea is not involved, remains transparent. It is the area between the limbus and the fornix. Now the conjunctival vessels are covering over the sclera, attached to the cornea at the periphery of the cornea, which is called the limbus, and it moves all along the globe over the sclera till there is a reflection at the periphery which is hidden under the upper and lower lid. That is called the fornix, and then the conjunctiva is attached to the tarsal plate, immobile, and is firmly attached with the tarsal plate, which is the inner surface of the lids. So the conjunctiva actually lines the inner surface of the lid. There is a reflection which is the fornix, and then the conjunctiva over the sclera. This conjunctiva is known as bulbar conjunctiva, and the conjunctiva which is at the inner surface of the lids is known as palpebral conjunctiva. Now, as a clinician, I would request you to, whenever you're examining an eye, just don't look at the bulbar conjunctiva. Try to look at the palpebral as well, because there are so many findings and pathology that we can actually see by doing a very simple maneuver is just pulling the lower lid outward, and you can use a torch and see the palpebral conjunctiva as well. Similarly, it's not very difficult to invert the upper lid. It's another 1 or 2 seconds maneuver, and you can invert the upper lid. You can see the foreign body, you can see the papillary or follicular reaction, you can see the scarring. So many findings could be picked up by these two maneuvers. Now, this is of course not a normal conjunctiva. You can see that the limbal vessels, lights off. Limbal vessels are, normally the transition is very smooth from the bulbar to the cornea of the conjunctiva, but you can see that there's swelling of the conjunctiva at the limbus area. You can see the dilated vessels, and the vessels are also visible here. Not only the vessels are visible here, there is swelling of the conjunctiva as well. Now, this part is the tarsal conjunctiva. Now, reaction of conjunctiva in the form of redness or any other pathology involves, in certain diseases, the bulbar part, and in certain diseases the palpebral, but generally both the conjunctivas are involved in a number of eye diseases. Now, if we divide the red eye presentation in the outdoor, we have to relate the associated tissues which are present around the conjunctiva, and they are, one way or the other, are responsible for the redness of the eye. Lids could be the reason, the lacrimal system, and then the orbit in which the eye is placed. Now, the lids, the commonest problem, as I mentioned last time during my talk, that the commonest problem, very at times overlooked, missed for one reason or the other, is the squamous blepharitis, dryness of the lashes, and there are scales. These scales very frequently are dropped in the conjunctival sac, and they cause irritation leading to redness of the eye. Now, these are the scales. You can see there are two types of blepharitis that we see in the clinical. A more common variety is a squamous dry type of blepharitis that you can see here, and a very rare aggressive form of blepharitis is an ulcerative blepharitis. That is very uncommon, luckily, but it's difficult to treat. Now, this is, you can see the advanced stage of the lashes, configuration and the appearance has changed, and the lashes are normally, they are actually convex downward in the upper lid and convex upward in the lower lid. You can see that they are distorted, they are misdirected, straight, small, and you can see that there is a gap between the lashes. So this is one of the outcome of long-standing blepharitis. The lacrimal sac, the lacrimal gland, and the other accessory lacrimal glands present in the lids, they can at times be reason for a red eye. You don't see red eye here because the lacrimal sac inflammation is limited to the sac only, and possibly there is a fistula formation here, and it has expressed out. Once there is regurgitation of the pus and purulent discharge backward into the eye, it can lead to conjunctivitis and red eye. Now, this is slightly different from this. This is the lacrimal sac dacryocystitis, as we call it, this condition as, and this is inflammation of the lacrimal gland that we see in various viral pathologies and some autoimmune diseases. This area is inflamed grossly, and the inflammation is not limited onto the lacrimal gland area, but has spread all along both lid areas. Orbital cellulitis, very common in children, and as I mentioned last time, there are two types of cellulitis. One is a pre-septal cellulitis, in which the inflammatory process is limited outside the orbital septum. The orbital septum is like a cartilaginous barrier between the eyeball and the outside. So inflammation outside the orbital septum is the preseptal cellulitis, and once the inflammation for one reason or the other has gone inside the orbit, it is called orbital cellulitis. In children, orbital cellulitis is a common presentation, and the reason is infected sinus. Most commonly eat white, and the other sinus can also be involved, but from there the infection can come into the orbit and there is inflammation of the orbital. You can see that there is orbital cellulitis. It is not a preseptal because there is congestion and redness within the eye, and another important feature is that the eyeball as such has pushed forward. Now compare this eye. Now the two eyes are there to compare with. This is a normal eye, but you can see that the eye is pushed forward here, what we call proptosis, with the inflammatory signs present in this part only. Now as a clinician, you know that it is a very, very sensitive disease or disorder to treat. To refer or treat, if you want to treat it, you should treat it very aggressively and urgently. The reason is that the communication between the vessels here and the brain is hardly, there's hardly any distance and barriers, and inflammation can travel inside the brain and it can cause very devastating complications. Now if we restrict ourselves to the redness of the globe, we start from the conjunctiva. Now there are a number of conjunctival conditions that can give rise to red eye. The commonest being bacterial or viral conjunctivitis, and non-infective inflammatory condition is an allergic conjunctivitis and some degenerative condition. But subconjunctival hemorrhage is a common presentation. Trauma, accidental damage to the conjunctiva. The vessels are very friable. Even on a very small touch, nail or any sharp object, there is a bleeding under the conjunctiva, and this bleeding can give a very horrible look, that the eyeball is absolutely red. I'm sure it's a common presentation in your clinic as well. This shows the injury somewhere here or here, and once the blood has collected under the conjunctiva, it has, due to the gravity effect, has traveled inferiorly. This hemorrhage is under the conjunctiva. We call it subconjunctival hemorrhage. Now the subconjunctival hemorrhage is a self improving kind of condition. It should be recovered in 3 to 4 weeks time. So important thing is to reassure the patient that nothing else is wrong, but the associated clinical finding or examination that is required with a subconjunctival hemorrhage is checking up of visual acuity. If the visual acuity is normal, the cornea, the media and the retina is healthy, and if the visual acuity is not normal, then of course probably some other injury is also present within the eyeball. Just have a look of the conjunctival, the corneal surface, see the integrity. If there is no the epithelial loss, you can see a good reflecting round corneal surface which is adequately wet. Possibly it's a normal cornea. But subconjunctival hemorrhage is a common incident that we see in the clinic. It's a self-healing kind of condition. You don't need to give any treatment because the hemorrhage is a sterile hemorrhage. There is no contact of the hemorrhage with the infection, though we don't expect bacteria or virus, and there is no communication between outside and inside. Normally bacteria are present in the fornix and they can invade only if there is a break or breach in the conjunctiva. Another picture of subconjunctival hemorrhage, but this is different from the previous picture, that you can see some signs of inflammation in the lid. So it's a conjunctivitis as well as subconjunctival hemorrhage. Now there are certain inflammatory conditions like viral conjunctivitis and very severe bacterial conjunctivitis can present with subconjunctival hemorrhage. So at times these needs to be, one should think of causes other than a traumatic cause of subconjunctival hemorrhage. Now it's a degenerative condition of the cornea. It's not inflamed now. The eye is not red. It's a pterygium, but at times the pterygium can be inflamed and the eye would be red. This happens to a susceptible individual. Not everybody has a pterygium growth onto the cornea, and the best way to protect it, my approach is surgery is the last resort. One must not touch the pterygium, especially in young subject. The reason is that the recurrence rate could be as high as 80%. So once we remove the pterygium head, and in 3 months' time, there's chances are there that it will regrow again. We remove it, it will regrow. It will keep on coming up till it will invade the whole of the cornea and obstruct the vision. So best thing is to avoid it. Now there is association of the dusty environment and ultraviolet light with the development of pterygium. So if those who are susceptible or they are in process of building up of pterygium, they should be advised to use to avoid dusty environment, number one. If not possible, they should wear good ultraviolet sunglasses. Now there are two types of glasses available. One is ordinary sunglasses that we see present everywhere, and there are specialized ultraviolet sunglasses. These UV filter glasses, although they do not stops 100% of UV light, but to a major extent, like 70 or 80%, and they can protect the eye not only from development of pterygium, from number of other conditions which we have discussed during the last lecture. Now sclera can lead to redness of the eye. The pathology in the sclera, if the pathology is in the episclera, it is episcleritis, and if it is in the deep scleral tissue, it is scleritis. Now one thing which should be remembered here is deep scleritis is not a simple disease. Whenever present, it is secondary to some chronic autoimmune process which is going on in the body. Episcleritis is inflammation of the sclera presented. It may present with a simple or a nodular form. It is a self-limiting condition, and it does not usually require any treatment. So, and the other thing about episcleritis, it's a small area of conjunctiva which is involved. Rest of the conjunctiva is normal. Now there are eyes which are very sensitive to medication. They react to either to medication or to the preservative that is present in the eye drops. They have very specific kind of redness, and the redness is only in the dependent area, which means the exposed scleral area and the lower conjunctival sac. If you ask the patient to look down and pull the upper lid, the upper conjunctiva would be absolutely normal. So contact or allergic eyes to drug or preservative can be can be diagnosed on simple examination. Now scleritis is the inflammation of the entire sclera. So in contrast to episcleritis, which is a focal lesion, the scleritis is a diffuse problem covering all over the conjunctiva, the sclera which is visible and the sclera which is not visible to the human eye. And it is invariably secondary to some systemic diseases like rheumatoid arthritis, SLE, and other diseases. It could be post-surgical or due to chronic infection of the sclera. Now this is the episcleritis. You can see that's a focal area of dilatation of vessels. Rest of the conjunctiva and sclera are healthy. And the very simple to diagnose is, if we just move the conjunctiva, it will be mobile over the dilated channels. So this is a point which differentiate focal conjunctivitis from episcleritis. Now this is scleritis. You can see that the whole of the sclera is involved. The vessels are very grossly dilated. You can see some exudate here, and you can see these dark areas are thinning of the sclera. Now this is during the disease process in these systemic scleritis. In the later stages, the area become thin and thin. So what we see here, we see the choroid, of course, is lying within the sclera. We see the choroidal shining, which is a pigmented tissue shining through the sclera over here. Now whole of the sclera, this is a scleritis. It's a very, very difficult situation to treat, and at times these eyes they catch infection and they go into phthisis. Corneal abrasion is a common presentation, accidental touching with the help of some pointed object or nail. Adults usually come when they get some injury from children in their lap. It's the loss of the corneal epithelium. Now this is of course is a white color, it's a white light, and this is some different color that you can see here. Now I would advise you to keep this dye in your clinics. Now, it's very simple. It has no bad effect. You cannot overuse it, but it's very informative. It can give you very good information about some pathology in the cornea. Now this cornea is damaged in this area by some trauma, and there is loss of some cells of the epithelium. Now a defect is produced. This defect is of course visible. We can see that with the help of some magnified system like slit lamp. But in the GP clinic, you can put a dye which is fluorescein dye. There are strips available. We just put the strip in the eye for about 2-3 seconds. The eye secretions takes up the dye, and if we use a blue light, we can see that the dye would be staining the defect. Now this defect is it's like a gutter. It is a defect in the continuity of a corneal epithelium. So if you know that there is a defect, you can properly manage it. Now this dye, you need a blue light. The quality of this dye, it's an orange color dye in this light, and when we throw blue light, it absorbs blue light and emits green light, which means it has the capability of absorbing one wavelength and emitting another wavelength. So if these blue light, cobalt blue light, are available in the ophthalmoscopes, and I'm sure you have ophthalmoscope in your clinics. So it is one of the filter in the ophthalmoscope has got a blue light, so you can directly diagnose a defect in the corneal epithelium, post-traumatic usually, and the treatment is very simple. Putting some antibiotic drops or ointment and patch the eye for 6 hours. If the defect is small, it will recover in 6 hours. If the defect is slightly larger, it will recover. It will take little more time, maybe 12 hours or 18 hours. But in less than 1 day or 24 hours, most of the defects in the corneal epithelium heals by itself. Vernal catarrh, allergic conjunctivitis, seasonal conjunctivitis is very common, and we see the seasonal allergies throughout the year in Lahore, but especially during March, April, and during September, October. Now, the conjunctival epithelium is exactly, it is like the epithelium of the nasal cavity, and it is like the epithelium of the respiratory system. So all the allergies which can cause allergy to the respiratory system. Nasal allergy can cause allergy in the eye. And the eye allergy is of course red eye and itchy eye. And there is a constant, rubbing that the patient complain of. No, it's not viral. It's inflammatory. It's not infective. I'll come to the viral part later on. It is inflammatory allergic reaction. Now, vernal catarrh, out of the allergic condition that we see in the clinic, vernal catarrh, it is a specific disease, and it is, you can see, usually begins in the pre-pubertal years and lasts for 5 to 10 years, causing whatever bad effect it has to cause, and then it settles, not completely, to some extent. Boys are more prone for the reason that we don't know, and it is often associated with asthma and eczema. Now, in milder form of vernal catarrh, there is some swelling of the conjunctiva, and you can see the dilated vessels. In advanced stages, these dilated vessels forms a loop over here, but in very, very advanced stage, these development of this tissue under the lid, on the conjunctiva under the lid, normally does not appear here, because these are the papillae of the conjunctiva, which are generally present in the palpebral conjunctiva, and due to intense allergic reaction they starts hypertrophy, and you can see they appears cobblestone type of appearance. Now, in 1 minute the eye blinks for about 15 times. Now you can imagine, if the 15 times, if this uneven ruffled cobblestone lesions blinks or rub the cornea 15 times a minute, how much damage it would cause to the cornea and how much discomfort it would cause to the patient. In very advanced stage, this is the in vernal conjunctivitis, there are giant papillary proliferation. Now let me, regarding that question on viral conjunctivitis leads to hypertrophy of the follicles, which is a normal reaction of viral inflammation. But in allergic conjunctivitis, it is the papillae hypertrophy that we see as cobblestone. In very advanced stage, you can see these papillae could measure 5 millimeter in diameter, and they are very, very large, giant papillae that we can see in the advanced stages. The seasonal eye allergies can range from mild to severe and may occur with a full package of respiratory allergy symptoms. So, one way or the other, they can be related to the respiratory system allergies. Pollen, dust, pet hairs, smoke, environmental pollution are the most common cause for chronic and seasonal allergies. We are doing some study on the seasonal allergies that we have in Lahore, and in my experience and that I have with the patients in Lahore, it is the smoke exhaust from the vehicle. That's the main cause of allergy to the eye. Since there is not a lot of rain which would settle these exhaust, or wind which will take away the exhaust out of the environment, the exhaust, lead mainly, remains in the environment and is a major potent allergen that we have these days. Now, it's just for the pictures are for, I hope, photographic memory is the best memory. If the eye itch, it's the allergy. If the eye burns, it's the dry eye, and if the eye is sticky with discharge, it's bacterial conjunctivitis. Sorry. Which should be immersed in water all the time. That's the reason of underwater swimming. You can open the eye while swimming. So eye should remain wet, and the wiping effect of the lid 15 times a minute spread the tears uniformly over the cornea. There has to be a basal secretion to keep the eye moist. Not only it will give a comfortable feeling to the patient, it will give a clearer vision. So once the eye is not producing sufficient tears, there are dry patches which comes up. It will obstruct the vision and it will cause the patient a very burning feeling. And dryness of the eye is it's one of the common presentation or common clinical presentation that we have. Tearing, redness and pink eye. In the early stage there is watering. In the later stage, due to the allergic damage to the glands, there is dryness of the eye. Now, management is for both allergic conjunctivitis and vernal keratoconjunctivitis, which is specific conjunctivitis, is primarily to go out of an area where the allergen is present. Practically, it's not possible, of course. But we have some modifying drops which modify the course of the disease. The vasoconstrictor decongestant can improve the general appearance of the eye. It will stabilize the blood vessels. It will not leak. It will allow for the allergens and the allergic response to leak out of the blood vessels. And there are some treatment which stabilizes the mast cell, like lodoxamide, and of course topical steroid. As I have mentioned last time, is 50% of the drops that we use that we have in the pharmacy contains either solo steroid or combination steroid. So, but to our good luck, this new thing, the non-steroidal anti-inflammatory, they are now available. So if for one reason or the other you want to use something which the steroid do, you can safely use non-steroidal anti-inflammatory. Ocufen, Naclof, Feni, and there are a number of drops, 10 or 15 drops available in the market. So that's a decongestant. Nafzolene or phenylephrine can be used as a decongestant. Now, viral conjunctivitis, the number of viruses can involve the conjunctiva and the cornea. There are viruses which can only affect the cornea. There are viruses which can affect conjunctiva only, and there are viruses affecting both. But for our interest, we have only 4 or 5 types of viruses. Adenovirus. Now, adenovirus is a virus which is responsible for the epidemic conjunctivitis. Now, this epidemic conjunctivitis, every year we see during the humid environment, June, July. There is always epidemic. Families, all members, if not all, number of family members reporting with a swollen eyelids, diffuse watery eye, and a very red eye, and very, very uncomfortable. Now, the redness, the conjunctival reaction with the viral conjunctivitis is a follicular reaction, and there is, but at times it can involve the cornea. When this adenoviral, it has different types, type A, type 3, which are normally involved in the epidemic inflammation. When it involves the cornea, it usually involves the cornea in a nummular fashion. It is called a nummular. You can see the small spots. These are the virus plus the white blood cells complex located in the cornea. Once these nummular opacities, it's visible with the torch examination. It is visible with the torch examination, and once these nummular opacities appear in the cornea, they go very, very slowly, and they have a chance of recurrence every year to come. The adenoviral conjunctivitis occur with it's highly contagious. Now, one thing is, don't worry in the management of the these adenoviral epidemic conjunctivitis, it will not transfer to you or for those who are involved in the medical profession unless there is free hand-to-hand contact. So the secretion has to be transferred, and the commonest mode of transfer is handshake, touching of the eye and the eye, and the touching of the secretion, and then touching your own eye. That's the reason. Otherwise, if you see 100 of cases, it will not be transferred. It's not an airborne problem. And another thing is, those who are infected with the adenoviral conjunctivitis, they should have their the towels and their pillow separated, and they should not shake hand. They should not share handle. Door handle is another mode with which it is transferred for all those who are using the door, opening the door and then touching their own eye. Epidemic outburst during the humid environment, I already mentioned that it's a very fulminant, comes up very quickly. It comes up in 2 to 3 days, but settle in 7 to 10 days time. No matter we give treatment or we don't give treatment, it will generally, as a rule, should be better, because it's the own defense mechanism is taken care of. We just give treatment to make the patient comfortable, and the treatment is to avoid the secondary infection that the patient is very sensitive to or at risk of. So we can give some antibiotic. If the patient is still not very comfortable, non-steroidal or steroid eye drops can make the patient very comfortable. And another local treatment is puts fomentation over the eye. That will also give a comfortable feeling to the patient. Now, as an ophthalmologist, we are not very worried about the adenoviral epidemic. We are more worried about the herpes conjunctivitis or keratitis. It's a serious problem. Out of the herpes simplex as well as the herpes zoster, herpes simplex is a serious problem. This herpes simplex, it has got two types of presentation: type 1 face, lips, eyes; type 2 genital herpes. The problem with the herpes simplex infection is, number one, it usually affects the young subject, children, number one. Number two, it's a recurrent disease. The problem with this virus is it normally settles or remain dormant in the ganglion, and when the immunity is low, either from the environment part or from the individual part, it comes up again and again and again, and it won't go even in decades. And thirdly, it will affect the vision permanently in the form of visual deterioration. Now, herpes simplex keratoconjunctivitis could be primary and then recurrence. Recurrence, of course, is more common. The ocular signs are presence of lid vesicle, follicular conjunctivitis, and keratitis when the cornea is involved. Now, cornea can show small loss of epithelial cell, which is called punctate epithelial erosions. Then the numeral opacities, you have already had a look in one of the previous slides. Now, this is the classical presentation of herpes simplex keratitis, dendritic ulcer. Now, it's the appearance of this ulcer which has dendrites and extension pseudopodia, and the ulcer heals very, very slowly. And in the later stage, there are disciform ulcers or opacities that we can see. This is one of the active ulcer during the early stage of the disease. This it again seen in white light with the dye. You can see the dye remain here, which is orange dye, and it typically shows dendrites. Once it will heal with some opacity, and when the opacity is there, the vision is dropped because of the opacity. Now, this of course it is right not in the central area, but it's close to the central area and can to some extent affect the vision and drop the vision. Now, this is a central pupillary dendritic ulcer, very beautifully stained with the dye and seen in cobalt blue light. You can see that the ulcer has got pseudopodia, and it shows a typical dendritic appearance. Now this is not a dendritic appearance, but it's the advanced stage, which is the disciform keratitis. But one more important thing, as a clinician, as a general clinician, I think you should be able to, of course, pick up the corneal finding, but not to leave or forget this important sign, which is hypopyon. Hypopyon, presence of pus in the anterior chamber. Now it is visible as a board shape with a flat horizontal border. Could be present in inflammatory condition and generally, but in infective condition we see this reaction in the anterior chamber. Of course, the lesion is in the cornea, the reaction is in the conjunctiva as well, but the reaction is in the anterior chamber as well. It's a very, very important sign because it shows or it reveals that the inflammatory process is not limited to the cornea, it has gone inside, which means a very, very aggressive treatment is required in order to save the eye, otherwise it will not stop and go on. There's another very advanced disciform keratitis. Whole of the conjunctiva is to some extent involved. This is the lesion, but you see this cornea as corneal edema in this area, which means that the lesion, of course, only present in the central area, but has involved the whole of the cornea, and you can see the signs of inflammation in the diagnosis is very simple: history, recurrence, and typical appearance of dendritic ulcer, which even are visible even without the help of fluorescein dye. So with a torch examination you can do that. The treatment is very simple. Treatment is antiviral treatment, oral, acyclovir, which comes by the name of Zovirex, 5 days treatment, 400 milligram 4 hourly, and then topical acyclovir, which comes by the name of Zovirex, 0.3%, and the dose is 5 times a day. But of course these antiviral are very toxic, you can't use it for a very long time. In eye we don't go beyond 5 weeks or so. Herpes zoster, the involvement of eye or involvement of cornea in herpes zoster is least likely feature. Involvement of conjunctiva is slightly has more chances for herpes zoster to involve the cornea, but the involvement of the lids and the skin in the corresponding nerve is more than the conjunctiva and cornea. So luckily herpes zoster involvement for the eyeball is not that dangerous, and it generally involves the lids and heals with a scar and dry eye. Anterior chamber pathologies can present with red eye, iritis, uveitis, or anterior uveitis as we call it, inflammation of the. Now uveitis could be primary, which means there is no cause which could be there, or it is secondary to some process going on systemically. So all these Bassett's disease, Reiter's, SLE can present with uveitis, but 65% of the uveitis that we see in the clinic is idiopathic, and we don't see any reason, or we don't find any reason in the eye or in the body. Local inflammation like herpes inflammation or adenoviral inflammation or bacterial inflammation can go within the eye and involve the uvea and cause uveitis. The uveitis is could be 3 types of uveitis: anterior uveitis, posterior uveitis, and the barrier is the lens. Inflammation anterior to the lens is uveitis, inflammation posterior to the lens is posterior uveitis, and when both anterior and posterior are involved, it is called a panuveitis. Endophthalmitis is the inflammation of all the 3 coats of the eye, the retina, choroid, and the sclera. That is endophthalmitis. Acute angle, I'll touch the acute because this is something very important. Acute angle closure glaucoma, and then lens induced inflammation. They all can present with red eye. Out of these 4, these 3 are medical emergencies. So it can damage the field, it can damage the vision, it can cause permanent visual loss, and it's a potential blinding condition. So early diagnosis and picking up of the findings and then managing it or referring it is a hallmark of management of these three conditions. Now, glaucoma we normally divide into a primary or a secondary. Second to any cause within the eye or systemically. Primary when we don't have any reason which occurs to only susceptible individual. Now it could be acute or chronic. Chronic can also be known as primary open angle glaucoma. That's not the topic for today. It's the acute. Now out of different glaucoma, the primary or the secondary, acute presentation of glaucoma in your clinic or as with us is a medical emergency. It's a potentially blinding condition if left untreated. Now what happens is that suddenly there is increase in the eye pressure. The normal eye pressure is 10 and 20 millimeter, between 10 and 20 millimeter of mercury. Pressure in acute congestive glaucoma goes very high. It goes in the range of 60 and 70 millimeter of mercury. Now that's the pressure which can actually physically obstruct the veins, and once it obstructs the vein and the capillaries, it can cause damage to the optic nerve. So it's very important to diagnose this condition and to break this attack as early as possible. Now acute angle closure glaucoma. What happens in angle closure? In angle closure glaucoma, the front part of the eye, the aqueous is formed by the ciliary process in the posterior chamber, and through the pupil it comes into the anterior chamber, and from the angle of anterior chamber there are trabecular meshwork, and then the canal of Schlemm, it goes out. A balance is maintained between the production and the drainage. Now the eye pressure can go high for two reasons. Number one, if there is overproduction of the aqueous. Number two, if there is under drainage of the aqueous humor. Generally it is the under drainage which is responsible. Overproduction is a very transient problem which the eye can take care of, which the eye can take care of it very easily, but it's the drainage problem which is responsible for increase in the eye pressure. In open angle glaucoma, this opening is absolutely normal. It is the problem with the trabecular meshwork and the canal of Schlemm that they are not receiving or draining the aqueous very easily, so the pressure go high. But that's an insidious process. The pressures are not very high, and it is there for years and years, and in years they have caused a little bit of damage. It's a progressive but very slowly progressive condition. But in acute congestive glaucoma, there is no problem with the trabecular meshwork. There is no problem with the canal of Schlemm. It is the peripheral iris which physically obstruct the angle of anterior chamber. I am going to show the picture of to make an idea about this condition. But we divide it into in 5 different stages. A latent stage in which the pressure is in the process of rising. Patient normally does not present in this stage.